So good afternoon, everyone. I thank Dr. Pramod, organizers MISSAB 22, for this opportunity. So after the wonderful talk by Dr. Comp, you might by now know the advantages, disadvantages of the foraminal approach. But I'll be talking on migrated disc. Definitely there is a role of migrated disc transforaminally. So thanks to all these pioneers who helped the endoscopy become better today. So as you know, full endoscopy is a single channel, single working channel with a saline irrigation technique, which offers a wide mobility, variety of techniques can be done with a single port. Advantage being the excellent magnification and visibility because of the irrigation, and obviously it is least invasive. So these are the things I use, the various angle scopes, sizes scopes you can use for various approaches. So again, there is always a debate which is better. So I always say both are complementary to each other. So both should be learned because most of the time you need both. So again, why transforaminal approach for migrated disc? If you just for next few minutes, I'll make things clear why transforaminal. So again, as you all know, the interlaminar definitely carries some retraction on the root. So transforaminal approach, you are landing in the disc space below the dura, that is anterior to the dura. So most of the time handling is less. And transforaminal approach, though we know the mobility is less, the moment we come out of the disc space and we are fully outside, that's an outside out approach, definitely you get a lot of mobility, and pedicle to pedicle approach can be done very well. The best part of transforaminal approach for migrated fragments is decompression of the exiting root. That's the best part where interlaminar approach cannot do sometimes. So this is where with the interlaminar approach you see the window. The transforaminal approach, just to show the window where the transforaminal cannula reaches there. So this cadaveric dissection is done to just to show what transforaminal approach without violating the facet can be done. So all a beginner should know when dealing with the migrated fragments, the anatomy, the pedicle above, pedicle below, and the facet. This anatomy, if you can orient yourself, practice yourself, so it's all have to do work around this place, and the important structure being the exiting nerve. So again, which level we are working, as Dr. Comp said, the upper levels of foramen is wider, the superior facet is away. So always there is chance of neural injuries high when you are working above, so be very careful there. As you come to L4, 5, most of the time the facet always protects the traversing root. So the safer is the 4, 5, as you go up you should be careful regarding the neural elements because the bony anatomy is more away from the thecal sac. The various classifications, again, Lee et al. Divided these zones into 4 zones, the upper 2, lower 2, the far upward, and near downward and far downward zone. And this latest classification, what the literature is from the Korean group, where Engan further divided this into, added 2 more grades to it, the superior very high and inferior very low, very high. So the advantage of this classification is to, if you can stratify your migrated disc prolapse, you can, grade 1 and grade 6, better you go interlaminar where transforaminal approach become too tedious. It can be done from expert hands, but as a beginner it becomes too tedious, you have to drill too much. So for just an example, in this case it's a migrated disc, inferiorly migrated L4, L5 disc here. So I went through 13 centimeter. So go there, place the needle. So as Comp already showed that you just plan either inside out or come out and work outside out. So you just go there as a beginner, always safe inside the disc, land inside the disc, then you can come out. Once your needle is in place, put a guide wire, pass the dilator, so you can just tap it in further. So all you need to be in the posterior 1/3. In this case, we have an inferior migrated disc, but not very high migrated. All once you enter there, do a C-arm shot, and then just try to rotate the sheath inferiorly. So this is what I have done. So I go inside. Once you can just orient yourself. Here we are on the right side. So this is a. I just fast forward it. So I just inferiorly you can see I just remove some tissue subannular to clear the area. That's the facet. That's the superior facet you are seeing. I just you can see that's the superior facet, or what you call it, ascending facet. All you need to do work, just drill that facet. So I'm just doing small drilling towards inferiorly and try to remove the fragment. So I'm not happy still, there's a fragment still there in the recess. I just come out little bit and try to drill the base of the facet further with the articulating burr there. So once it is done, so grab the fragment and just pull it out. So small 4 to 5 mm of drilling is enough. And the upper migrated fragments you can see here is L23 up migrated fragment. So here I am entirely in the foramen, not going inside. So I'll just fast forward it. So I'm just there. You can see I have landed in the axilla. That's the facet, just overhanging the facet there. Cranially I will be seeing the exiting now. I'll just create some space so that I should not put traction on the exiting now. So I'm just drilling the non-articulating part of the facet there towards cranially. I just use sometimes this chisel, which is very useful, make things faster. Once I drill there, I cut the ligament. Now you can see that's the exiting root, that's the ganglion, that's the traversing root, and between that will be the fragment. So I just hook it out. You can see that fragment is coming out. This is entirely extra discal, extra ligamentous. So it's extruded part. But never be happy when you remove one fragment. So always try to see more fragments will be there. So unless you see the epidural space bleeding or epidural fat, try to put a hook and remove the fragments. So just trying to remove multiple fragments here. So now you can see that the space becomes a little bit pulsating. That's the last bit of the fragment to be removed. So now you can see the dura is well pulsating. I can see the dura well there, anterior dura. You can see the dura there. So that's the traversing root. I am just decompressing so that I can have a good lateral recess decompression also. This is the traversing root and the exiting root, ganglion well seen there. The fragment entirely has come out. So with a simple post-op MRI, the fragment is completely gone, disc not violated.
Dr. Sura, can you?
Yeah, it's 2 minutes only. So it's one more case where just to show you the fragment which is there. This is a post-op. It's a previous scar and the current, there was a previous laminectomy done in this patient. So this is one more patient, it's a post-op. So one more case, again inferiorly migrated. So it's a up migrated case one. So and just fast forward. So it's a post-op. That's entirely fragment is removed. That's a disc space. It's a pulsating. So take-home message. So the transforminal technique is a very important technique for migrated fragments, especially patient has previous surgeries. The patient underwent a previous laminectomies. It's the best approach you can without violating the dura. But again, when you want to know which technique is better, so try to learn both techniques. Both work very well, and in experienced hands, one can do 90% of the work with one technique. Thank you.